In terms of the individual components of CBT-I, sleep hygiene is the most widely used and disseminated component of CBT-I, but it's the least effective. In fact, as monotherapy, there's not been any papers showing it's an effective strategy. And we've actually used sleep hygiene as the control measure in a lot of our CBT-I research in the last 20 years. People with perfectionistic thinking get drilled down on their sleep hygiene, and they just actually get more rigid in their thinking about sleep. One of the behavioural strategies for CBT-I is sleep restriction therapy, which is limiting time in bed as close as possible to people's actual sleep time. People with sleep problems behave aspirationally around sleep. They go to bed for the sleep they wish they could get, rather than the sleep that they could realistically expect to get. Sleep restriction is about reducing that time in bed, and we do that by doing the same sort of visual sleep diary, having someone do the behavioural experiment of mapping that out for a week, and then adding up how much sleep they actually had. In this case, it was 38 hours of sleep in the week, averaging 5.4 hours per night, and then allocating them that amount of time in bed plus 30 minutes in the subsequent week, agreeing on the timing. So we agreed on 12:30 a.m. to 6:30 a.m. with that 5.5 hours of sleep plus 30 minutes, and pretty quickly had a consolidation of sleep, so less wakefulness during the night. Now, the key difference is there's a bit less sleep. So 34.5 hours sleep that week as against 38 hours, but the time spent in bed changed markedly. So instead of 61 hours in bed, there was 44 hours in bed that week. So 17.5 hours less time in bed awake in 1 week. So that one frees up a lot of time for people, and also is a lot of time they're not in bed, promoting conditioned arousal response around sleep or ruminating around sleep. The second behavioural component of CBT-I is stimulus control, and that's really the recommendation that reinforces the association between the bedroom and sleep. So go to bed only when you're sleepy. If you can't sleep, get out of bed. Thinking of it as controlling the stimulus to want to be in bed trying to sleep. So it's stopping that trying to sleep. Relaxation training. The aim is to upskill people in a strategy for reducing that arousal or sitting with distress. And although we haven't used it a lot traditionally in CBT, I think of DBT as a really helpful component of this, of sitting with distress, a really important skill. Another way of thinking of it is to be a good sleeper, you've got to be okay with just empty space. So if someone's not okay with just quiet empty space while they're awake, they're going to have trouble sleeping, because that same rumination, motor restlessness, inability to tolerate that empty space that's a problem during the day, it's going to be even more of a problem at night when there's less distraction. So part of that relaxation training is just having people have something they can do, both as a distractor and to be a bit more comfortable with empty space. And then the last component of CBT-I is cognitive therapy, really alleviating excessive worries and misconceptions around sleep, and largely that's psychoeducation. This is often the nut of CBT-I, and working with people with sleep problems, particularly in the mental health area, is just challenging unrealistic sleep expectations and this narrative or attributional biases that sleep is the cause of many things or is going to result in significant consequences.